Now we're going to talk about the control of respiration. Respiratory rhythms are regulated by higher brain centers, chemoreceptors, and other reflexes. We'll look first at the medullary respiratory centers located in the medulla oblongata. They include the ventral respiratory group and the dorsal respiratory group. The ventral respiratory group is our rhythm-generating and integrative center. It consists of a network of neurons that innervate the inspiratory muscles and cause them to contract. The VRG sets up eupnea, which is the normal respiratory rate and rhythm. It's set at about 12 to 15 breaths per minute. The use by the VRG of inspiratory neurons excite the inspiratory muscles via the phrenic and intercostal nerves. This excites the diaphragm and the external intercostals, respectively. And we believe that the expiratory neurons inhibit the inspiratory neurons in a reciprocal inhibition network. The dorsal respiratory group is a network of neurons also in the medulla oblongata that sits behind the ventral respiratory group. It takes information from stretch receptors and chemoreceptors about respiratory rate and rhythm and sends that to the ventral respiratory group. The pontine respiratory centers are located in the pons of the brainstem above the VRG and DRG, but we know the pontine respiratory center communicates with the VRG in order to smooth out the transitions between inspiration and expiration, especially when information is being transmitted to the inspiratory muscles during speaking, sleeping, or exercise. A lesion in the pontine respiratory center areas may lead to apneustic breathing, which is a type of dyspnea where a patient takes prolonged inspirations. Here we can see that the pontine respiratory centers are located in the pons above the VRG and DRG, and that the ventral respiratory group is in front of the dorsal respiratory group. In order to generate the respiratory rhythm, we believe there are pacemaker neurons. These pacemaker neurons are in the VRG, and they control intrinsic rhythmicity. The most widely accepted hypothesis is that there is a series of reciprocal inhibition with two sets of interconnected pacemaker neurons, and that each neuron set controls the other to ensure rhythm so that they don't fire both at the same time. Instead, one fires and causes inspiration, the other fires to inhibit that inspiratory signal, and we get expiration. Breathing rate and depth is determined by how active the respiratory muscles are, and they are stimulated by the respiratory centers. So if there's greater stimulation by the respiratory centers to the inspiratory muscles, wherein more motor units are excited, that would increase the depth of inspiration. So rate is definitely determined by how long the centers are active, and there are certain characteristics and conditions where both are modified by changing body demands. Some of those respiratory centers would respond to things like chemical factors, or influence from higher brain centers, or pulmonary irritant reflexes, and even the inflation reflex. Let's look first at the chemical factors. Changing levels of carbon dioxide, oxygen, and pH are the most important chemical factors to pay attention to in how the breathing rate and depth are affected. These chemical factors are going to be monitored by central and peripheral chemoreceptors. Central chemoreceptors are located in the brainstem. Peripheral chemoreceptors are located in the aortic arch and carotid arteries. The most potent and most closely controlled chemical would be carbon dioxide. Carbon dioxide is the most potent respiratory stimulant for influencing breathing rate and depth. For example, if in the blood the partial pressure of carbon dioxide rises, that's called hypercapnia, so a buildup of carbon dioxide in the blood. It's also called carbon dioxide retention, but this CO2 accumulation would cause the increase of hydrogen ions in tissues that this blood is near, such as brain tissue and joint tissue. And the hydration of this carbon dioxide with water would eventually lead to that carbonic acid and then the production of bicarbonate and those hydrogen ions. So when the carbonic acid dissociates, so when carbonic acid breaks down into bicarbonate and hydrogen ions, it ends up releasing those hydrogen ions near tissues like the brain and joints. And that is going to result in a drop in pH, and the acidity of that environment near tissues like the brain and joints will be communicated to the peripheral and central chemoreceptors. And they synapse with the respiratory regulatory centers in the brainstem. So the respiratory centers would then increase the depth and rate of breathing, which would increase pulmonary ventilation, and that would lower the partial pressure of carbon dioxide in the blood because it would increase the expulsion or exhalation of CO2. And that would mean that pH no longer is down or more acidic, it would then rise to normal levels. If the partial pressure of carbon dioxide, though, decreased, meaning we're not retaining CO2, we're reducing the amount of CO2 in the blood because of possibly slow and shallow breathing, then something like sleep apnea or apnea may result, which is breathing cessation that occurs when carbon dioxide levels drop too low in the blood. Swimmers can voluntarily hyperventilate, and hyperventilate also causes the partial pressure of carbon dioxide to decrease in the blood. But when swimmers voluntarily hyperventilate, they cause that drop of carbon dioxide, but that's also going to get rid of their most potent stimulant for respiration rate and depth. So they're tricking their body into not resuming respiration, but this can lead then to dangerous drops in oxygen levels in their blood. And for swimmers, this means they could drown if they pass out. So this chart is an overview of what occurs with ventilation when we have abnormal amounts of carbon dioxide in the blood. This example is looking at an increase in the amount of carbon dioxide in arterial blood. That information is going to be picked up by both peripheral and central chemoreceptors because an increase in carbon dioxide in the blood will lead to an increase in hydrogen ions in the blood and cause acidic environments for both neighboring tissues and the blood itself. In order to decrease the amount of carbon dioxide and make pH rise, the medullary respiratory centers signal the inspiratory muscles to contract. When they contract, this increases pulmonary ventilation and leads to more carbon dioxide exhaled. As a result, the partial pressure of carbon dioxide in arterial blood will return to normal and pH will as well. So, hyperventilation, which swimmers we looked at could voluntarily do, sometimes occurs because of maybe an anxiety attack, but what it leads to is decreased levels of carbon dioxide in the blood, or hypocapnia. So hyperventilation is increased depth and rate of breathing that exceeds the body's need to remove CO2. So what happens is we exhale more CO2 than we need to, and that's reduced the CO2 levels in the blood. This can cause cerebral vasoconstriction or ischemia, result in dizziness or fainting, and early symptoms can be as simple as the tingling of the fingers or some random muscle spasms. But the treatment would be to be breathing in a paper bag because you are going to be breathing back in the CO2 you exhale in this or with this treatment. And so that should make your CO2 levels in your blood rise and return your pH back to normal. Because during hyperventilation, blowing off that much CO2 and lowering your CO2 levels in the blood will also decrease hydrogen ion concentration in the blood, therefore make your pH rise or become more alkaline. And that needs to be brought back to normal. Other chemical factors that affect breathing rate and depth are the partial pressure of oxygen. Now, this isn't a major stimulus for changes in respiratory rate and depth because it requires a substantial drop in arterial partial pressure of oxygen in order to stimulate increased ventilation. So while the peripheral chemoreceptors do monitor how much oxygen is in the blood, it has to be a substantial drop to affect ventilation. We can see the location of the peripheral chemoreceptors here in the carotid bodies and in the aortic arch. So that's what this image is showing you, is the location and innervation of the peripheral chemoreceptors. Next, we're going to look at the influence of arterial pH. We've already talked about the fact that if carbon dioxide levels increase, that causes a decrease in pH in the blood. If carbon dioxide levels decrease, that causes an increase in pH in the blood because of the connection between carbon dioxide hydration and the generation of hydrogen ions. Well, we can have pH change regardless of carbon dioxide and oxygen levels in the blood. And pH changes can still modify respiratory rate just like they did when we were looking at conditions of hypercapnia and hypocapnia. Now, pH is monitored by peripheral chemoreceptors, just like oxygen, and decreased pH could be reflective still of CO2 retention, but things that are metabolic, like the accumulation of lactic acid from muscles that have been performing anaerobic glycolysis, or even excess ketone bodies in those that are breaking down too much protein, these can also cause decreases in pH, so it doesn't have to be a respiratory stimulus. The respiratory system would pick up on these changes in pH, then attempt to control that pH by increasing or decreasing respiratory rate and depth. In this example, decreased pH would be corrected by attempting to raise pH by increasing respiratory rate and depth. So let's summarize our chemical factors that are influencing breathing rate and depth. Rising carbon dioxide levels are going to be your most potent, most powerful, your biggest respiratory stimulant for influencing respiratory rate and depth. That's important. I would circle it, highlight it in red, say it to yourself multiple times. We also looked at pH and partial pressure of oxygen and how they influence breathing rate and depth. And oxygen and pH are going to be monitored by peripheral chemoreceptors, but they are not going to be as powerful a respiratory stimulant as CO2. You have to have a substantial drop in the partial pressure of oxygen for it to be a respiratory stimulus. And pH, while it can be a respiratory stimulus that causes changes in breathing rate and depth, it's usually going to be metabolic factors that indirectly, through peripheral chemoreceptors, cause changes in breathing rate and depth. So arterial pH does not have to change because of respiratory factors. And we'll stop there for right now. In the next part, we will look at the influence of higher brain centers on breathing rate and depth.